Evening. Welcome once again to a phenomenal time of sharing, education, expertise, a time for you to answer questions. Our partnership with WMed, we thank Dr. Cheryl Dixon and WMed and Mount Zion for this tremendous partnership where we come actually to the community, and we want you to be aware of what is going on, be able to ask questions from your own home. And so right now, tonight, we're going to be talking about COPD. And if I got this right, it's chronic obstructive pulmonary disease. We're going to be talking about that. If you know anyone that has that, we need you to share right now. We need you to like and get as many people on board tonight as possible, because we've got phenomenal information that's going to be useful for you, and you're going to be able to use this as you go forward to help deal with this whole idea of COPD. So we'll be discussing what it is, some symptoms, who gets it, prevention, some treatments. So all the questions that you've been wanting to ask, you can ask those tonight. And we've got individuals here that's skilled, that's educated, that has expertise and experience in this field that can give you some real and relevant answers. So tonight, once again, welcome to this time of community sharing on health concerns in our community. We're coming to you once again live from the studio at Mount Zion, a partnership between WMed and the Mount Zion Baptist Church. Let me open with prayer. There's a prayer, a scripture in 3 John 2. It says it like this: I wish above all things that you prosper and be in good health, even as your soul prospers. So we know that God wants us to be healthy. God, we thank you for this time of sharing. We thank you for preparing individuals with information and expertise that can speak in the lives of those now that have these types of diseases. Thank you now for their energy and their expertise and their willingness now to share and to give themselves to our community. We honor you now tonight, Lord, with this broadcast of information to these your people. In the name of Jesus, this is thy servant's prayer. Amen. I'm once again excited, Reverend Chris. We're back again. We're back, and we've got a tremendous panel. And so thank you for co-hosting again. And so it's been a minute, but we're back.
Yeah, we're happy to be back once again here for a community conversation. And I guarantee it's going to be incredible, and we're going to learn something and have some actionable things to do as a result of it. Pastor Moore, I think we're going to need some help to make sure that we get individuals on. So if you are on the platforms, if you don't mind, could you please take a moment and share and let somebody know that we are on and we are live. And the reason we would love for more individuals to come on tonight is because these conversations are rich when we have your participation, when we are able to answer the questions that you have, and we will read every question that we receive as much time as we have live today. And we have some experts here with us who can intelligently talk about COPD. And I'm not going to try to say what those letters mean. But we have some folks here who can intelligently talk about it. So if you don't mind, please, ma'am, please, sir, share and let somebody know that, matter of fact, let everybody know that's following you that we are live. And to those of you who are happening to catch the replay, thank you for replaying this. So
and we've got like all kinds of people in the sanctuary tonight.
Yeah.
Can you see all the people in the sanctuary?
Yeah.
Yeah, it's filling up.
Yeah, researchers and directors and man, I'm all over the place.
All over the place. So they're in the sanctuary and you are virtual. So Reverend, who do we have? Who are our individuals now that can share, that have this experience and ready to give information tonight? Who do we have?
First of all, it is my privilege and pleasure to present once again Dr. Mark Schauer of internal medicine, and he is retired now, so let's thank God for him and welcome him to the panel. And Dr. Schauer, if you don't mind, as I introduce you, you got a joke for us, don't you?
These are so harsh. Yeah, well, it's one, the question was, am I retired? And I'm partially retired. I still do some educational work at WMed. Because it's true that old doctors don't retire, they just lose patients.
That was good. That was good.
Very good.
So how are you connected to this COPD?
So COPD is a condition where, well, we'll talk about definition of it first, maybe is best. It's a COPD stands for chronic obstructive pulmonary disease, so it really defines itself in its definition. So chronic meaning it's long-standing, obstructive meaning there's some blockage to airflow, but it's a chronic disease, and it's treatable. It is in most cases actually preventable, and you can prevent it from getting worse. And it is a disease that it really is not reversible, though, once you have it. Most people, it has to do with limitation of airflow, so airflow within your airways or within the small air sacs of your lungs, and that would be more emphysema, but it's all under one heading. And the reason to suspect that you might have it if you have some shortness of breath, especially with activity, and if you have a cough and sputum production. So those are the things that would make you think, oh, do I really have something that's a lung disease? And whether you know it's COPD or not is then dependent upon seeing a medical provider and have them take a history and then perform some testing.
Awesome. Well, thank you so much. Also on the panel tonight, we have Michael Hess, a respiratory therapist. And if you don't mind, come on, let's thank God for him tonight being a part of tonight's panel. Put those hands together virtually. Come on, put some emojis in the chat. Michael Hess, thank you so much for coming tonight. And of course, you've brought some fans with you tonight.
I did. Shout out to my wife out in the audience here supporting me out there. My wife is a nurse practitioner and is in research, but as Dr. Schauer rightly pointed out, her most difficult job is probably being married to me. So,
Well, awesome.
so I have a slight joke.
Yeah.
One, maybe a better, not quite a joke, but a little story. The scripture quote tonight really spoke to me because I'm also a big Star Trek fan, and of course, one of my favorite quotes from that is "Live long and prosper." So that really, it's almost like you picked that for me tonight. So thank you.
Oh, wonderful, wonderful. So you being a respiratory therapist, and how are you connected to this subject of COPD?
Well, I have been a respiratory therapist for 16 years, and so being that COPD is a long-standing lung disease, this is something I've seen very often. I did work at WMed for about 4 years up until 2020. My current role is with the COPD Foundation, so we're actually a national organization that works on behalf of people living with COPD and their family members and everybody else in the community to work on prevention efforts, research efforts, education efforts, to make sure people access the tools they need to be able to live their best lives with COPD. Wonderful.
Thank you so much. And last but certainly not least, we have tonight Dr. Faith Thornton. And you were on before, right?
Yes.
Welcome back once again, a family medicine resident. And we are ecstatic to have you tonight. So if you don't mind, put some emojis in the chat and let's thank God for Dr. Thornton for being with us tonight. So Dr. Thornton, similar question for you. How are you connected to the subject of COPD? And if you got a joke, go ahead and share that too.
I don't have a joke. I was trying to think really hard, but I couldn't think of one. But as far as my connection to COPD, as a family medicine physician, this is a condition that I see all too common, particularly in our inpatient service. It's not uncommon for us to admit patients with COPD exacerbations. Sometimes those can be due to respiratory infections, which is why today, later on, I'll emphasize the importance, particularly in this season, in getting vaccinations to prevent those infections that may cause worsening of COPD and exacerbations that may need hospitalizations.
Well, thank you. So we have individuals on Facebook, on YouTube, and the Mount Zion app. So if you are on the Mount Zion app, you can also chat in using the Mount Zion app. So big shout out to our First Lady, Sister Gwendolyn Moore. She's on the Mount Zion app tonight streaming. So thank you so much for tuning in. So let's jump into our conversation tonight about COPD.
Okay, I see individuals, you're coming in. We need a few more coming in. I see the numbers coming up. That's great. And so, once again, spread the message really quickly because we only have an hour, so that means we got about 53 minutes left. So you got to get in because the information is getting ready to start flowing. And so, here's the first question, panel. And
Pastor Moore, as you ask your first question, just want to make an appeal. Whatever question you have, go ahead and put those in the chat right now. And then, so don't wait until we get to a subject. If you just think about it, go ahead and put that in, and then we'll have those queued up. Thank you, sir.
And we'll try to make sure we answer all your questions before they leave. If not, they'll leave with the questions and they'll send the answers back. So here's the first question. Let me ask, what cultural group is most impacted with this whole idea of COPD? Let's just jump into that one.
So I can
Dr.
address
Shower.
that. So, interestingly, the cultural group that is most affected is Native American, American Indian. At the highest rate is in that population, and it really has to do mostly with cigarette smoking, but it also has to do with environmental exposures, especially those at work. Places where there's more air pollution, you're going to have more COPD, and those are the biggest causes of it, are cigarette smoking and environmental exposures. So smoking in the United States, in 1965, over 40% of the population smoked. Now it's less than 14% of the population, and cigarette smoking, again, is probably the biggest risk factor. African-American population smoking compared to Caucasian is pretty similar. It's in 14%, somewhere around in that range. And so that is really what pushes the risk of COPD. The risk is going to be for cigarette smoking and environmental exposures. 20% of people who have COPD have never smoked, and so those are individuals that either have a genetic predisposition and there is a inherited condition that can cause COPD, but most of those people would also have exposure because of pollution or because of environmental exposures at work.
So is there a difference between like male and female when it comes to COPD about that condition?
What we've been finding with more recent research is that women actually are slightly more affected by COPD. They tend to get it a little bit more severely, and it tends to be a little bit more higher prevalence. We're not entirely sure why, but it does seem to affect women a little bit more. And also to tailgate on what Dr. Schauer was saying, there's been in the last year or so, there's been a huge upswing of research that, as Dr. Schauer mentioned, about 20 to 25 people with COPD, 25 to 25%. I'm all flustered on camera. It's been a while. 20 to 25 people, there I go again, 20 to 25% of people with COPD have never smoked. And so what causes that? It's environmental things, it's genetic things. One thing we're really finding is that sometimes the seeds of COPD are actually planted in childhood. And people who have environmental exposures even as a child, if you live in an area with higher pollution and that sort of thing, can affect your lung development and then put you at higher risk later than life. So it's been an absolutely fascinating area to research in the last few years, and we're just learning more and more about it.
So a question came in. Can chronic asthma turn into COPD? And this is for anyone.
I'll take that one. So those are really two different conditions. The thing that really separates asthma from COPD is going to be the reversibility. So with the diagnosis of COPD, we'll do some testing, and with that testing, we'll give you a bronchodilator like albuterol. And if those symptoms that you're having, the shortness of breath and obstructive airflow, improve with albuterol, a medication that's more consistent with asthma. COPD really is chronic and doesn't change with the addition of the medication.
Wow. Can we deal with the symptoms one more time, and can we kind of tick through them a little slowly? Because I think, Dr. Sowers, you said there's a certain percentage have never been diagnosed that have it. Is that right?
Sure.
So can you share the symptoms, if you will?
So how would you even know if you have this condition? And you'd know if you have shortness of breath, especially shortness of breath with activity. And when you're tested for COPD, one of the tests that we do is actually a 6-minute walk. How far can you walk in 6 minutes? And if you can walk less than, 300 meters or something like that, that's one of the tests for severity of it. So shortness of breath, especially with activity. The second would be cough, and not everybody has that, but most people have some cough. And the third would be sputum production. Those are probably bringing up mucus. Those are probably the three most common things that people would have.
What's the third thing you said?
Bringing up mucus, having a cough that's productive. Yeah, so you can have a cough that's non-productive, right? A cough that doesn't bring anything up, or you can have a cough that brings up mucus.
So cough that doesn't bring up, that's a good cough.
I don't think any of them are that good. I don't want to go. But if you're having those things, you think, that's not. No, some things you just get used to if they go on to for a period of time. But there are treatments that are available that would benefit individuals. So that's why it's important to know about it.
And that's really one of the biggest issues that we have is this idea that there's a delay in being diagnosed with COPD, because shortness of breath with activity, it's kind of, it's not very specific. Am I getting older? Am I getting out of shape? Do I have this condition? People tend to adapt their lifestyles to accommodate this shortness of breath, and so it kind of gets pushed off more and more. And so that's why it's really important to listen to your body. And if you start noticing some of these things that you're not performing like you want to, make sure you're talking with your primary care provider in particular, and making sure you get some of these tests done.
I have a question here. Someone asks, I have, you can help me with what this is if I try to say it. Sarcoidosis. I said it right? Oh, wow. Look at that. I have sarcoidosis with scarring on my left lung from it. Could I be at risk for COPD?
A lot of times with sarcoidosis, we might see something more like what we would call a pulmonary fibrosis or an interstitial lung disease, where the lung gets a little bit more stiff and has some trouble getting oxygen in from the airways into the bloodstream and that sort of thing. That said, I do know a good friend of mine in the advocacy world lives with a condition called bronchiectasis. You thought sarcoidosis was tough. Try bronchiectasis on.
Yeah.
Which is where you get kind of these pockets of these chronic infections inside your airways, and they get kind of floppy. So that can be a form of COPD. It's sometimes considered a form of COPD. So you're certainly at risk for additional conditions, and that's when we would probably want to bring in some of the bigger guns like a CT scan, a CAT scan, to actually get a good idea of exactly what's going on in there and get you on the right treatment plans.
So is there an age where people are normally diagnosed with this?
I'm not sure. Older adults, I think, though. What would you say, Dr. Schauer?
Yeah, it's really unusual to see it before the age of 40, and most times you're seeing it in people that are 50 or 60. I mean, that's really when people, especially that when it's due to cigarette smoking. And I will point out that there's one genetic condition that if you smoke, you get it earlier, and so it depends on, one, what your environmental exposures are, but COPD from cigarette smoking, environmental exposures, usually age 50, 60, maybe in your 40s, but yeah. Whereas we see asthma, you see a lot of children, right? So you see asthma in children too, right?
Yeah.
More commonly.
Most individuals with COPD, like we said, the highest risk factor is going to be that smoking history, and most of those individuals have 10 to 20 years of smoking, so you really need that time frame of smoking exposure to really get the risk or develop the COPD from the smoking.
So is it improving now because individuals are smoking less as a population, right? So is the condition getting less in our communities?
So I can tell you worldwide, there were over 3 million deaths from COPD in 2019. And before the pandemic, it was a third leading cause of death in our nation.
Wow.
Since COVID was the third most common cause of death for 2020, 2021, it got bumped to fourth, but it kind of blended because if you have COPD and you got COVID, you had a double strike against you. So it's significant in terms of number of people that are affected, the cause of death, and not only that, but how it affects somebody's quality of life. You can imagine that if you're short of breath and you're coughing a lot and you can't do the things that you want to do, it really adversely affects what you do and affects those around you.
And again, unfortunately, as we've seen the smoking rates go down, we have seen rates of things like air pollution and things like that going up. So we have these other risk factors and things that we're learning about that can also impact COPD. So it's still considered the most common or the what we call a non-communicable disease. So a communicable disease is something you can get like the flu or something that you catch from another person. Something like COPD is not communicated from one person to another. It is one of the leading cause of death in these non-communicated diseases. So it is, to a degree, I guess, getting better in some aspects, but it's still a significant, major health threat.
So along the lines of the smoking, someone wants to know that exposure, does that also include secondhand smoke?
Yes.
Yes.
Secondhand smoke exposure, things like dust, and occupational exposures, like if you work in a coal mine, you really want to be careful and follow the guidelines that your employer has as far as PPE and protecting your lungs and not inhaling that. Or if you're even doing like lumber work at home, you really want to be mindful of inhaling those dust and particles as well.
And it's not just tobacco smoke. You know, around the world, we see this idea of wood smoke and other what we call biomass fuels, things that are burning things like wood for heat, for cooking, and all that sort of thing. And in some parts of the world, that's actually a greater risk factor than tobacco smoke. So any kind of these smoke particles and, as you said, the dusts and fumes and things like that.
Okay, so now individuals have, now you talk about the fire, individuals have like fire pits now in their backyards, and that's become very popular. So is that, could you get from that smoke?
Probably wouldn't get it just from that unless you're having a fire every day and sitting by it all the time. But
Okay.
it could potentially make things worse. We do see a lot of people who aren't able to be around even neighbors and things like that who have fire pits going and that sort of thing. So it probably wouldn't cause it, but it can certainly cause what we call a flare-up or an exacerbation.
So it does, now you're talking about an environment that we live in, that does matter then, because for example, on the north side of Kalamazoo, there's this tremendous smell, and it's been here for years and years. So that's not healthy then, when you're talking about the odors and the environment in which individuals live in.
Yes, that can definitely increase your risk.
And so you can potentially a community that's been being impacted if that persists over time, which it has.
Potentially, yes.
Interesting. Okay.
So we mentioned that COPD is not reversible. So what does a person do to manage COPD? And I think I just heard too that it could be fatal because it was the third cause of death before COVID. Wow. So what does a person do to manage COPD?
Hey, do you want to take that?
I would say the best thing that you could do is to eliminate the triggers and the exposures. Again, kind of thinking about COPD is going to be a consistent exposure to a toxin that's going to cause chronic inflammation. So if you're smoking a pack a day, you're having inflammation in your lungs for that entire day. So the very first thing you want to do is stop smoking, be mindful of smoking exposure, decrease your exposure to secondhand smoke. The other thing that you want to do is, like I mentioned earlier, is stay vaccinated. Because you have a compromised lung, COPD is really an umbrella term that involves two different conditions. It's chronic bronchitis and emphysema. So the chronic bronchitis element is really, like Dr. Schauer mentioned earlier, it's going to be that mucus plugging. That chronic inflammation is going to cause increased production of mucus, which is going to cause that chronic productive cough. Those mucus plugs are going to get stuck into the small airways and prevent you from inhaling and exhaling, which is going to cause decreased oxygen and increased CO2. So that's really what our lung is doing that exchange of oxygen. We're breathing in the oxygen and exhaling the CO2. So with the compromise of that exchange, you don't have as much oxygen and increased CO2, which is going to cause symptoms. So that's what I would say. Decrease your exposures. Make sure that you stay vaccinated so that you don't have things like flu and pneumonia. Because your lungs are compromised, you definitely will fare worse and have increased risk of hospitalization and COVID vaccination as well.
So push that a little bit further, Dr. Thornton, because you mentioned the vaccination, COPD and COVID. Can you deal with that a little bit more, how important it is to be vaccinated, or how dangerous it is if you have that, with COVID being prevalent?
Yes. So the main manifestation of COPD is just going to be that your oxygen is going to be low. Like normal human beings, most of us are walking around at 100% oxygen just based on our normal lung function. Most people with COPD stay within the range of 88 to 92%. So because you have that decreased oxygen concentration, it's going to be really important for your lungs to stay as healthy as they can. So when you get infections like flu, pneumonia, and COVID, you're really just putting more work and pressure on your lungs that are already compromised and can't give you that good oxygen exchange.
Thank you.
Somebody asked a question, what is COPD exacerbation? I don't know how to say that word. I'm gonna just stick with Nehemiah and Revelation, stuff like that. But how do you say that, not how do you say that word, but what is COPD exacerbation? EXACBERATION. Yeah.
Exacerbation.
Yeah,
Which
what
just
is
means
that?
an acute worsening. It gets worse like all of a sudden, like over. So it's a chronic condition where you're chronically short of breath, and then something happens, something intervenes, and then you get more acutely short of breath. So you find it's harder to walk up a flight of stairs, it's harder to walk across a room, you're coughing more, and oftentimes there's more sputum produced, or your cough is worse, and you're producing more mucus, and your mucus may look nastier. So that's how you define it. And it usually is caused, like Faith was saying earlier, it's usually caused by an infection. Viral infections are common, but bacterial infections are not uncommon too, which is why the pneumovax is such a, the Prevnar vaccine is such a good vaccine to get. But it's an acute worsening, usually caused by infection.
Because that word is such a mouthful, we're trying to start using the phrase like a COPD flare-up or a COPD flare or something like that. It's a little bit more, it brings to mind a little bit easier visual on that. You can understand where all of a sudden everything is flaring up. You got your knee joint is flaring up in pain or something like that. Everybody kind of understands that. So I guess my other joke for the night is we in medicine never say in 3 syllables what we can say in 15. So we always like to throw those $10 words out there.
Amen.
True story.
So I think, Reverend Chris, you kind of started down this road. So how do we manage it? So you've got it and it's not reversible. So then how do we manage it, the quality of life for individuals?
Right. So one of the things that we really work to do is to get people to stop smoking cigarettes. Because all of us have some loss of lung function just with normal attrition with age. As we get older, nothing works as well as it did when we were younger. Take my word for it. I can tell you that for sure. But when you smoke, it continues to go downhill more rapidly. So we try and get people to quit smoking. So that instead of a more rapid decline, it's a slower decline. And it's really hard because maybe now's the time to talk about cigarette cessation a little bit. Cigarette smoking is an addiction to nicotine. It's not just a habit. It's really hard to quit. And in fact, nicotine is one of the most addictive compounds on the planet. That's why the cigarette companies are so happy to have us smoke a lot of it. So maybe we should talk a little bit about cigarette cessation.
Sure.
Faith, do you want to say something about what you use for patients to try and get them to quit?
Oh, yeah. I think one thing that I found that has been interesting with my patients is that I find that a lot of them have smoking associated with something throughout their day, where they drive and smoke a cigarette or drink coffee and smoke a cigarette. And it just really goes back into that habitual thing where it's just sometimes just a habit almost. So I think one of the things that I have my patients do is to separate the cigarette from whatever thing that they do habitually. Just if you usually have a cigarette with your coffee, just have your coffee without the cigarette. And then most times people find that after doing that for some days, when they separate the habits, that they find that they will decrease their smoking. There are also medications that we can give to help with smoking cessation. Wellbutrin is one that I use often to help patients decrease their nicotine addiction. That seems to have some effects or some improvement for patients. Things like Chantix, I don't use a lot. Now, there's some side effects, but definitely the benefit outweighs the risk with Chantix as well. Patches, gum, lozenges, anything that you can do to really try to exchange the nicotine habit of smoking is going to help you. Really, just burning in that fire is really is the worst thing that you can do for your lungs, and burning the lung parenchyma, the lung tissue, and causing inflammation. So exchanging it for a lozenge or a patch can be helpful for the lung health in particular.
So how about the other opportunities, chemical opportunities to smoke other than cigarettes? How does that impact COPD?
Vaping?
Yeah.
That's an
Yeah.
interesting question.
So there was a study a couple years ago, they had 900 patients in it, and they gave half the people, they had them vape, and the other half they used and it was nicotine they were vaping, and they used regular nicotine replacement products, patch gum, lozenge, that sort of thing. And they followed them for a year, and the people that vaped, 18%, I think it was, or 19%, stayed off of cigarettes altogether, and in the other group that just had nicotine replacement was probably like 10%. So there is some thought that perhaps it would be a way to have people not smoke cigarettes, because then they're at least not getting in all the noxious carcinogens, cancer-causing agents that are in cigarettes. We work to try to not do that, but that might be a last resort that would be of some benefit.
But doesn't that cause some kind of effect also? Or does it?
Yeah, there was a big thing a few years ago, and people were putting their own substances and own oils in, and especially when they mix it with THC or CBD sometimes. And there was this It was a inflammatory lung disease that was pretty severe and actually killed some young people in Wisconsin and Illinois that used it. So there are some adversities from that, and there's adversities from using vaping just in general. And it's not it's like 20% of our population of high school students vape on a regular basis, and I think in middle school it's still even like 5 to 10%.
Really?
It's amazingly bad. Yeah.
And really, we honestly don't fully understand what the long-term effects are going to be. You know, we've had the vaping device has been around for quite a while now, but it's only been prevalent probably in the last 10, 20 years or so.
Right.
So we don't really know what's going to happen another 10, 20, 30 years down the road. We don't know what kind of long-term effects they're going to be. And while it's probably true that these devices have less harm than traditional cigarettes, that doesn't mean they're harmless. You know, the cliche is kind of the only thing that really ought to go into your lungs is air. So I always hesitated to recommend them, except that, like as Dr. Schauer was saying, as a last resort. You know, if you've been around the block a time or two with your cigarettes and nothing else has worked to try to quit, then vaping might be an alternative, but only in very, very few cases, in my personal opinion.
So how about the marijuana or the weed smoking?
Again, that's similar risk because you're inhaling hot smoke, fire. So I would say it has similar risks. I don't know if the studies are out yet to really list marijuana as a risk factor, but just thinking about the mechanism of anything that you're smoking in that's hot and smoky is going to increase your risk.
Okay,
Yeah.
Oh, you want to go
I
ahead?
was just going to say, I would second that. We haven't done a lot of research on it just because we haven't been allowed to really. But what we have seen is that it's actually potentially even more damaging than tobacco. So,
Okay. So quit smoking. What else?
But before we get to the quit smoking, someone asked a question, or pretty much put a plea out there. I would like to get help to quit smoking cigarettes, and it's been a while now, and I'm trying to stop but cannot. So how does this person get help?
Go to your PCP, and like I said, there's lots of options. There's medications, patches, lozenges, like I mentioned. So there definitely are lots of resources that you can do, as well as like psychotherapy as well. For sure.
Who's a PCP? What's a PC?
Sorry, PCP stands for Primary Care Provider, so just your doctor.
Okay, sweet.
And there's behavioral therapies that can be helpful for cigarette cessation too. And those can be individual or group, and there are some things online, there are apps on the phone, because it takes a lot of support. It takes a community to help you quit smoking. And there's also, for some people, acupuncture, hypnotherapy, there's other things that may be of benefit as well. So
we've found that the best approach is usually a combination, to address the nicotine addiction. We have the patches and the gums, et cetera, the counseling, the behavioral therapy, all that sort of thing. The most important thing to remember is if a particular therapy or combination of therapies doesn't work for you, that doesn't mean that you're a failure. That doesn't mean that you're never going to be able to quit. It just means that that combination didn't quite work out. It takes most people several tries to actually quit for good, so don't give up if something in particular didn't work for you.
Right, the old saying is, if at first you don't succeed, quit again.
Okay, quit smoking. Now, what else we do to manage it? Because the individual, if it's not reversible, so I quit smoking, but I still have it, how do I manage it?
Most people with COPD are on controller inhalers, so those inhalers include medications like long-acting bronchodilators or inhaled corticosteroids that will act as controller medications. So people with COPD should see their doctors regularly, and if your symptoms are uncontrolled, there's different levels of treatment that we would escalate based on how severe your symptoms are. So if that will be stronger steroid inhaler, longer acting beta agonists or dilator, so definitely controller inhalers are going to be super important for those individuals as well.
So go ahead, doctor. Go ahead.
I was just working in a short seminar working with some of the residents, and Mr. Hess was there as well, and he can speak really nicely to like what inhalers you might use and how they're used and that sort of things. Do you want to address that?
Yeah, sure. So we've got basically three main types of inhalers that we would want to use. We've got what Dr. Thornton referred to as beta agonists, I think you said, and we also have these other drugs called muscarinic antagonists. So again, we got our $10 words. Basically what both of those do is they work on a couple of different chemical paths on your body to help your airways relax a little bit. A lot of times people with COPD, their airways kind of spasm down a little bit, and we help those relax. Then another class of drugs that Dr. Thornton mentioned were inhaled corticosteroids, and those can bring down some of the inflammation, or swelling that's inside your airways. So, a lot of times people have these tightened down airways, and then they're also thick, and that's why it's so hard to get the air in and out. So we have these controller medications that help you do a little bit better day to day or on a daily basis. And then we also have short-acting inhalers where you may have a small flare-up in your symptoms where it's not quite that full-on of exacerbation where you're going to have to go into the hospital or go to the ER or anything like that. You just need to get kind of over the hump a little bit. So we have those medications to help too. There are a couple of other things that we can do out there, a couple of other medication classes, but those are really kind of the mainstays of our therapy for most people with COPD. And there are even, down the road, there are even some surgical things we can do. And sometimes we can thread a tube down into your lungs and put little valves in there that help your lungs deflate a little bit better. We're really doing a lot more with a lot of the medications and with a lot of these interventions. The one thing I really wanted to hit was activity. I know it often sounds kind of weird if you're out of breath, getting short of breath, going from here to the restroom or going to check your mail. Running on a treadmill is probably not the first thing that pops to mind, but we found that activity is really one of the best things you can do. And we often try to refer people to a program called Pulmonary Rehabilitation or Pulmonary Rehab, where you actually learn you're monitored for a while in a gym, connected usually with one of our hospitals. We've got a couple programs here in town. You're taught how to exercise appropriately for your level of severity, how bad your COPD is. And then you're also taught other things like how to use your inhalers properly, because we're really good at telling people to use drugs, but we're not always so good at telling people how to use drugs. So we teach you how to use these inhalers properly, we teach you when to use them, and we teach you other things like good nutrition, breathing exercises, and a lot of those things. So we really do have a lot of approaches these days. While we can't cure it entirely, we can, again, as I mentioned before, we can really help people get as healthy as they can be. I actually, a couple weekends ago, another good friend of mine from the advocacy world raced in the Chicago Marathon despite having advanced COPD and using a portable oxygen device. He has a co-runner that carries extra batteries for his oxygen device, but he ran the Chicago Marathon in 6.5 hours. So I don't even think I could drive the Chicago Marathon in 6.5 hours.
So it's not reversible. So is it does it get better, I guess? Because you said we can, a healthy lifestyle of exercising, the right drugs, knowing how to use those, nutrition, so we can improve the quality of life, like not breathe as hard longer, like we can start breathing easier. That's what I'm hearing you say?
That's really one of the major goals, is to improve quality of life and reduce your risk of flare-ups, because we also know that those exacerbations, the more you have, the more you're likely to have in the future. So that's really kind of our two main goals of care, is to reduce your symptoms and reduce that risk. Can we reduce it to zero? No, but we can. It's certainly treatable. You know, we never call it curable, but it's certainly treatable. One of my a good friend of mine out there in the advocacy, another good friend of mine in the advocacy world, says that his ultimate goal is to pass away with COPD, not from COPD. And with our modern treatments, as long as people can access them and know to access them, and you know, that's a whole other issue, is, you know, how do we make sure that people are connected with these resources? But when we do that, we can really make a big impact in quality of life.
So is medication always necessary for COPD treatment?
I think it's depends on the severity of the lung condition. So one of the things that many physicians' offices, most physicians' offices has is barometry, so you can assess the lung function and how much air you can force out altogether, and compared to how much air you can force out in 1 second, and compare what those values are to what normal is. And there are studies that show that you enhance people's performance and their quality of life if you treat them with some of the inhalers that Dr. Thornton and Mr. House were talking about. So they're used because they often enhance the individual's quality of life, and the ones that are used are usually long-acting, these LAMAs and LABAs, these long-acting inhalers that they use.
Yeah, and it's kind of a function of that topic we were talking about before, where there's that delay in diagnosis. Most of the time, people with COPD don't get diagnosed until they've lost a large chunk of their lung function. So, you know, again, these and some people don't even get diagnosed until they're in the hospital with their first flare-up. So by the time you get diagnosed, you're probably at that point where you need the medication. So is it absolutely necessary in every case? I mean, technically no, but practically virtually everybody who's been diagnosed is on some kind of medication.
That's another question about diagnosis. Is there such thing as early diagnosis with COPD?
What do you think?
And the reason I'm asking is to give you some thinking time, you know, because we're hearing most people don't know it until later, until something happens. So, like, is there some type of way to, I don't know that in my PCP, my doctor, I mean, we can discover, like, okay, we're kind of heading down the wrong path here.
And because I think it allows you to intervene earlier. You know, you've already mentioned correctly that the use of the inhalers doesn't change the course of the disease. It improves quality of life. It doesn't save lives, but it helps people function better and lets them be more physically active. I think intervening earlier with getting rid of exposures, getting rid of cigarette smoking, environmental exposures, that sort of thing. I think that makes a big difference.
So does it lead to, because oftentimes we've got quite a few people now that's walking around with oxygen. Is that one of the treatments, or is a result or from COPD? Does that?
Yes, sometimes people do require oxygen supplementation for COPD. For the reason I mentioned earlier, oxygen saturations are just decreased in that population just because they can't get the oxygen exchange into the blood. So sometimes they can't keep their oxygen up to where they need to be. The oxygen that we're breathing now in this room is about 21% oxygen. So what we do when we give them oxygen through the nasal cannula is increasing the concentration of oxygen so that they can get higher, I'm gonna try not to use science word, I wanna say diffusion, but get more oxygen into the blood. So sometimes oxygen is necessary. And then as far as the question about early detection, the way that we diagnose COPD clinically is having a chronic cough for 3 months is really the first sign of COPD. If you just are having productive cough for 3 months, within a 2-year span, it can skip months. But if you're just having that chronically, you definitely want to go to your PCP and say, hey, this cough isn't going away, and that can start us going down the line of looking towards diagnosis.
Now, push that a little bit now, because I think that's something that our audience really need to know. And can you slow that down and do that one more time? Because oftentimes individuals are having these type of symptoms, but we're not doing anything with them. So can you do that one more time? Say that one more time for our audience. So I really want us to get that.
Yes, so I would say the first insight into some concern for COPD would be chronic cough for 3 months within a 2-year span, chronic productive cough, or even just chronic shortness of breath or shortness of breath with exertion. You definitely want to mention that to your primary care provider to start looking into diagnosis of COPD.
So don't ignore that, right? And I think that's when we're talking about taking control of our own health. So there are some things. So if my body is doing this on a consistent basis, then I got to get going and like, look, I need you to take a look at this. We need to do something with it.
For sure.
The earlier we can find COPD, the earlier we detect it and start treating it, the more we can slow its progress, and the better your quality of life is going to be. So never ignore what your body's trying to tell you. And I like that phrase, take control of your health.
Yeah, I think that's a big deal, particularly, and I think you said something earlier, one of you doctors said that if your body starts functioning differently, we really need to have that taken care of. And we need to
You have
get
to say
active.
something to your primary care provider.
Yeah.
Definitely mention it at your appointments, yes.
Now, I'm going to ask a question I think somebody's going to ask, maybe they didn't ask, but okay, if you don't have a primary care provider, like quite a few people in this community do not. They don't have access to them or don't have one. So what does that person do? I've got this. I don't have a primary care provider. I feel something is not right, but what do I do? So.
In this community, I would recommend the Family Health Center. That's an excellent place for people to go if they're uninsured or don't even have money to pay. That's an excellent resource to start. Doctors, they have a lot of same-day appointments, so I would say start there in this community.
But you need to say something to somebody.
Yes,
We need to-
somebody.
Yes, okay.
So, I heard two things to address. Number one, so does COPD continue to advance? Because I heard you say we can probably slow it down. So does it continue to advance once you have it until departure? I mean, what's happening here with COPD?
In most people, it progresses a certain amount. We used to think like pretty much everybody, once you had it, you kind of had this kind of straight line going down. But again, we've got better therapies now. We can often slow that down. Now again, if you're plateaued at a place, if you're kind of even keeled like this, and then you have one of those flare-ups, then you're probably going to take a hit, and you're probably not going to get back to where you were on that. So it's a little bit different for everybody. It's a very mixed up kind of thing, and every individual case is a little bit different. But we also know that everybody, I think as Dr. Schauer mentioned earlier, everybody kind of loses some of your lung function as you get older. It's just part of the normal process of aging. So it's a combination of all those things, and again, that's why we sometimes will advance therapies and things like that, give you higher doses of particular medications, or, look at some of these other therapies. So, it's something that, again, we can kind of, hold the reins on in most cases, but yeah, I would say yes. Most people, it does advance to a certain degree or another.
A follow-up question with that. So if COPD was, you said, the third leading cause of death prior to COVID and then was bumped down to the fourth, and you said you have a friend who said that they want to die, eventually die with COPD, not from COPD. How does COPD cause death for a person?
I would also say that there's comorbidities with COPD, so people that have this have other things too, and controlling those helps their their quality of life. I'm kind of indirect, I'm like a politician indirectly answering your question. So gastroesophageal reflux disease, coronary artery disease, anxiety and depression, all those things go along with COPD. And part of the anxiety is if you feel you can't get enough air in, it's really an uncomfortable sensation. And the inability to do your normal physical activities leads to depression. So there's a lot of other things that go along with just having COPD. There is a gradual worsening of your breathing, and usually death from COPD is probably from acute exacerbation, an acute worsening, an acute flare that is just so severe you have respiratory failure. Your lungs can't work to, as Dr. Thornton was saying, to get rid of carbon dioxide and to take in oxygen, to do its basic function. It doesn't work to do that anymore, usually during an acute flare.
We've got about 10 minutes left. Make sure we're now getting ready for our wrap-up round. If you got any questions, make sure you please get them in. We've got individuals here ready to answer questions, just waiting to answer your questions. So make sure you get those in. And once again, if you know someone that has not joined in on this broadcast, get in touch with them right away and say you got about 9 minutes now before we wrap it up. So get those questions in. We've got the individuals here that can answer your questions, and we need the information to get to you and your family and everyone you know about COPD tonight.
Are there any key symptoms a person should prioritize sharing with their doctor that would lead a doctor to consider COPD rather than a general cold or other illness?
Persistence of symptoms. Yeah. Shortness of breath, cough.
Yeah, if it's not going away, then that's really the key.
Mm-hmm.
Gotcha. And one person just kind of testifying that the Cpap machine helps them. So it's okay. Praise the Lord.
So yeah, that's another one of those. Dr. Schauer was mentioning comorbidities. A concurrent condition that goes along with COPD is called obstructive sleep apnea, and you might have them separately, but then if you're diagnosed with COPD, they can affect it, make it worse. So CPAP machine can help you breathe a little bit easier at night, can help you not stop breathing in some cases. You might have a condition where some of your neck muscles kind of collapse down a little bit, and it doesn't wake you up enough that you wake up, but it wakes you up enough that you're not sleeping very well. So we did a study a few years back where there was a significant overlap between the sleep apnea world and the COPD world. So I would agree that CPAP can be a real game changer for a lot of people.
Just a question I missed from earlier. Can past work in the coal mines cause COPD later in life?
Potentially, it can cause a couple of different lung diseases. So, yes, short answer.
All right. I think
Okay.
I'm caught up.
We're getting ready to wrap up. We got about 7 minutes now. Is there any question, doctors, that we need to know? I mean, anything you need to say that we didn't ask? So take this moment now to talk to our audience and share your heart based on your experience, based on what you've seen and what's happening in our community. So if there's something else we need to know that I'd like to share and get this out, please do it, and we'll start with Dr. Thornton.
All righty. Well, I would say that the most important thing to do is if you're not a smoker, please don't start. If you have people who are around you who are smokers, try to encourage them to quit. If you are a current smoker, to go to your primary care provider to look for options to quit. Again, I want to emphasize the importance of getting vaccinations. If you have any lung condition at all, asthma included, COPD, it's going to be important for you to protect your lungs as much as you can because of the increased risk that you have. And also, I think that's what I would say. Yes.
Awesome.
So I would say always remember that you are not alone. Historically, COPD has been kind of one of these, I'd almost call it an orphan disease, where it has a big impact on our healthcare system, but it hasn't really gotten a lot of research funding. A lot of people don't really understand it, and so we've kind of had this idea that, well, there's not much we can do about it, so I'm going to give you a couple of inhalers, and we'll see you in 6 months or whatever it is. But we have a lot more therapies that are available, a lot more treatments, and we have a lot better understanding of it. And it's important that you realize that, I'll back up a little bit, we've also done a really good job as a healthcare system overall of making people kind of feel guilty about having COPD. It's one of those things, well, you should have known better, you should have not smoked, you should have done all that sort of thing. And we need to stop doing that. And you also need to understand that there are a lot of support groups out there too. You should also understand, I should phrase that poorly, you should understand that there are a lot of support groups out there that can help you along that path, people who have been on that journey, people who can support you and give you their insights and really understand what you're going through. I would often tell my patients that I understand COPD as a condition, but I don't have it. I don't understand what it's like to live with that shortness of breath every minute, so I'm not ever going to tell you I know how you feel. What I am going to do is try to connect you with other people who do know how you feel, and you guys can all kind of hash it out and support each other. So biggest thing is you are not alone, and we can help you.
So if I got just a couple minutes, which I probably do.
Yes.
So I really like what Dr. Thornton said about immunizations, and part of that has to do with taking charge of your own health care, and I think being your own best advocate. And even though there's a healthcare system, it's sometimes hard to get into that system and to find someone who will listen to you. So when you do, make sure that you're taking care of yourself and you're involved in that. So one thing that's a little bit different than what we talked about, but something that people who smoke cigarettes are certainly at risk for, is lung cancer. And I think part of taking responsibility for your own health, which I think most of us do, is to know that there is annual screening for lung cancer with a low-dose CT scan, but it would have to be ordered by your medical provider, by your physician or your nurse practitioner or PA. And it's available to anybody who's aged 50 to 80 who has smoked for at least 20 years and hasn't quit for at least 15. So I would advocate people to keep that in mind also, that we're trying to prevent really even worse disease such as lung cancer, and that is recommended by the American Cancer Society to be done on a yearly basis.
And so then, once again, take control of your own health, and something that all of us can do is diet and exercise. That helps. Just seems like that helps everything.
Definitely.
Absolutely.
So I said the
Yes.
same thing
Yeah.
with diabetes, right? I said take control of your own health care and be your best advocate, and diet and exercise, again, are key to all of this stuff.
Yeah, and this is a complicated process. This is a complicated condition, so never be afraid to ask questions and get the support that you need and deserve.
I think that was a huge point about exercise, that a person who's short of breath can still learn how to appropriately exercise, and that there is help available for individuals to learn to get that activity. Because I think some folk may think, since I'm short of breath already, it doesn't make sense for me to go ahead and exercise. So thank you so much for bringing that out tonight.
And Dr. Thornton, just before we leave, we've got about 3-4 minutes now. Just keep pushing that vaccine. It's vaccine. It's flu season now.
Flu season, yes.
COVID is still around.
Still
So
around.
just particularly in older people, how important it is that we get vaccinated.
Very important, and particularly because it is currently the season, flu vaccine, pneumonia vaccine, and COVID. There's the new COVID bivalent vaccine that I definitely would recommend for all people to get.
All right, great. Look, this has been phenomenal. We really want to thank everyone that had joined in. Thank you for sharing, and thank you for getting anybody's business to join tonight. This has been phenomenal. We have this relationship with WMed. They are willing to really get anybody we need to talk about health conditions. Let us know the type of things you want to discuss, and we'll share those, and we'll get individuals that can address whatever you need addressed. We can actually do that. And so we're grateful for you. And once again, keep the questions coming. And Reverend Chris, this is still going to be out in the cloud, right? So even after it's over, can you talk about that and thank our guests? And I think the last minute or so, you got it, so you can wrap us up.
Yeah, thank you very much. Let me first do this. The way to let us know what you would love for us to discuss is to go ahead and put that in the chat now. So if you don't mind, put that in the chat, and we will review even after we're off being live. So we'll have that list available. So go ahead and put it in the chat. Don't worry about if we've talked about it before or you don't know. Just go ahead and put that in the chat anyway. Secondly, this will be available on our Mount Zion app. It will also be available on YouTube and also on Facebook. so you can have opportunity to share this and to rewatch tonight's conversation. So if you don't mind, let's help me thank Michael Hess. Thank you so much for coming and sharing with us on tonight. Wonderful. Thank you, Dr. Thornton, for being with us tonight. Dr. Mark Shower, thank you for being with us tonight. And to all of you,
The studio audience.
the
You see,
studio audience,
it's growing.
thank you all for being here with us tonight. All of these wonderful researchers and nurse practitioners and directors and folk from everywhere up in the building on tonight. Amen. And all of you who are streaming around the world, thank you for tuning in tonight as well. Father, we thank you for what we have experienced and what we have learned. And as John prayed, we pray, God, that we are in good health, just as our soul prospers. Our bodies will prosper because of what we've learned tonight. In Jesus' name, amen. Thank you so much. Continue to put in the chat what you think we should discuss, and we love you. Good night.